Hello, my name is Isa Sayed, and my research clinical question is, did pregnant teenagers in rural Indiana have adequate knowledge of contraceptives before conceiving? So some background about this research topic is that adolescent birth rates are nationwide higher in rural communities than in urban and suburban areas. Indiana specifically has 49 rural counties, and our adolescent birth rate is higher than the national average. A lot of this, the higher birth rates with adolescent individuals can be contributed to a lack of proper sex education. Indiana specifically practices abstinence sex education, and in our state legislature, although it is not prohibited that we teach other sex ed courses, schools are not required to, and in some counties it is strictly prohibited either from the school boards to teach safe sex practices in sex education. So this is just a figure from a paper done in 2018, and this is just a federal research study, and it is showing that a federally funded program could decrease the rates of adolescent pregnancy, and they measure this in the average effective treatment, the treatment being the safe sex education. So looking at this graph, you can see that with more years of this program being funded, the average effective treatment, meaning the lower rates of adolescent pregnancy, decreases as you give teenagers more access to sex education. So for this particular study, the intervention that we'd be using is a survey. We would be surveying parents who had children under the age of 18 years old, and we'd ask them about whether they knew about contraceptives when they got pregnant. We would also want to have a control population, so this would be children or people under the age of 18 who did not conceive a child during that time, so people who did not conceive a child before 18. The questions that I'd want to specifically ask in this survey are, did your school formally or informally offer programs to teach students about safe sex practices? The answer choices would be yes, no, and unsure. The second question would be, did you conceive a child before the age of 18? The answers are yes and no. And then the third question is, were you aware of contraceptives and safe sex practices before you got pregnant / your partner got pregnant? The answer is yes and no. So after asking these questions in the survey, our hypothesis would be that people who answer no to the first question, meaning they say that they did not receive an informal or formal program from their school teaching them about safe sex practices, are more likely to answer yes to the next two questions. So this is essentially letting us compare people who did not have a program at school that taught them about safe sex practices and contraceptives, and compare those people to students who did have that access. And then we would see between the two groups who was more likely to have an adolescent pregnancy. So this is a cross-sectional study design. We're essentially taking a snapshot of a population at one point in time and getting the answer to these survey questions. So all participants in this survey will be from Indiana. They will have to be born between 1985 and 2010 in order for us to get a large enough sample size, because there probably wouldn't be a big enough sample size if we shortened the age range for teen pregnancy. We're hoping to get at least 5,000 participants. And the primary measure of this study is whether or not the participant conceived a child. A secondary measure that could be added to the survey could be whether they were aware of contraceptives, even if they did not get pregnant or their partner did not get pregnant. So this is an example of some categorical data. We're comparing whether or not someone got pregnant, prefaced by whether or not they received a comprehensive sex education. So because of this, we would be using a chi-square data analysis to compare the two groups and to see if there is any statistical significance between whether or not you had comprehensive sexual education and whether that the populations tended to have more adolescent pregnancies. So some limitations of this study are that participants may feel kind of uneasy answering these questions. This is a very sensitive topic, and teen pregnancy does affect people's lives in more than one way. It affects you psychologically and financially. It can have a lot of burdens, and it can be a sensitive subject if the participant may be considered an abortion or adoption, or whether they considered those two. They may not want to answer these questions. We're also looking at a few generations to get a higher sample size for our survey, because if we limited the birth years to 2000 onward, we would not have that many participants. And so by making it a wider gap, we can get more participants. But the caveat of that is that there are generational differences between people who might have had teen pregnancies, before 2000 and after. That could be due to changing attitudes. There could have been just like after 2000, people had more access to the internet, and so they don't just rely on school for safe sex education. So we could see some sort of a confounding variable when we're looking at people who were born before 2000 and born after 2000 because of there being access to sex education outside of school. Another limitation or factor to consider is that rural areas may just have a different lifestyle than urban and suburban areas. Some families may have planned on getting pregnant in their adolescent years, and that could just be due to their lifestyle and their values, and not necessarily a failure on the part of the education system. So ultimately, the translation of this is that if we ask patients about whether their pregnancy kind of was related to a lack of education on contraceptives, we may be able to identify that as a preventative measure, that by offering comprehensive sexual education, we can lower the rates of teen pregnancy. The way that this relates to providers and patients is that obviously if you have less teen pregnancy, you're going to have better patient outcomes, for those adolescents that became pregnant. They're going to have less health complications, financial complications, and psychological complications. And that whole patient population is going to overall be healthier without the extra stress of having a baby. Another possible engagement is that physicians might find it easier to give resources to teenagers who are looking to become sexually active if their schools are offering a comprehensive sex education. Physicians might be able to work with the local school board and the local schools in the area to offer their patients better access to safe sex and contraceptives. This relates to equity because, as we saw earlier with the figure And just from general research in this area, adolescent pregnancy disproportionately affects people from rural communities and underserved communities. And adolescent pregnancies lead to worse health outcomes for both the parents and for the children. This could be, again, due to those financial stressors and psychological stressors. And so by figuring out what is different and what resources urban and suburban communities have that the rural communities don't have, we can level the playing field and offer some sort of resource so that patients from this population aren't disproportionately affected. This is the source for the one figure I used, and I'd be happy to answer any questions. Thank you.